Hello, class. This is going to be your replacement lecture for the course that I missed, or the class I missed, our initial class. We are going to cover international healthcare comparisons. In your previous courses within healthcare economics, you've learned a lot about what inefficiencies the U.S. healthcare system has. We're just going to cover a few of those today, but we want to see how they are efficient, or inefficient, I should say, in comparison to other countries. So by now you know we spent a whole lot of money on healthcare. The most recent estimate puts us at about 17.8% of our gross domestic product. That is, all of the expenditures that occur within the United States is dedicated to the healthcare industry. And this trend has been climbing over time. So on the one hand, we can say, wow, we're spending a whole lot on healthcare. On the other hand, we can say this is a driving part of our economy. So it kind of creates this weird imbalance where, well, do you want to hurt the healthcare industry, which contributes so much to the general economy, but at the same time, you want to cut back on the cost of healthcare? So where do we spend our money? Well, this is in 2012 dollars. It still doesn't completely control for Obamacare, the Affordable Care Act, that is. But you can see that a majority of our expenditures come from private health insurance. We'll get to that in a little bit and why that category has grown the most. Next big area is Medicare, and then Medicaid. Now, Medicare is for individuals who are 65 and older, so this is really supposed to be the stopgap for health insurance when you are elderly, since that's when most of your health issues start to pronounce themselves. Medicaid is for individuals who are very poor. That number has grown over time, particularly because we have more income inequality, and also we have recently increased the level of poverty needed in order for you to qualify for Medicaid. Before, you had to be 300% below the federal poverty level. Now you have to be 133% below the federal poverty level. There are two other categories. One is out-of-pocket expenditures. This can include things like deductibles. It could also include items such as procedures or elective surgeries that are not covered by your insurance, as well as over-the-counter medications and devices of that sort. The very last part are state-run health insurance plans, typically aimed at children. There's also the Veteran Affairs group. Where does our healthcare dollars go? A lot of it goes to two major categories: hospitals and doctors. We have seen some substitution effects between hospitals and drugs, which is still a large portion, but there is some cost savings that is occurring from substituting the hospital doctor care with drugs. But the grand majority of it is hospitals and doctors. And doctors is one of these really difficult problems as well, because it is a big portion of our bill. Most of it is driven through salary, and we still have fewer doctor visits than any other nation. So when we talk about salary here, right, we want to say, well, we need to compensate physicians because they're taking on a task or a service that's very important. But how do they compare to, say, chief executive officers? What we have here is a graph showing us the annual mean wage for different categories of physicians as well as chief executive officers. Now, this is the mean wage, all right? This is the mean wage. You're going to notice that we have a couple of bubbles here. The zero bubble is our median, and the triangle bubble here is our 25th percentile. Clearly, there's more to the left-hand side of this graph. I just wanted you to see where the median or mean values are. And we can see that anesthesiologists, in terms of thousands of dollars, they earn about $235,000. This is back in 2010. Surgeons, on average, earn about $233,000. Oral surgeons, $219,000. Obstetrics, $212,000. Orthodontists, 196, internists 188, physicians and surgeons of all other types that don't fall into one of these categories 187, family and general practitioners 183, psychiatrists 182, and then we get to chief executive officers at 1780 at 178,000. Then pediatrics and dentists, and finally down at the bottom, nurse anesthesists. And so we are compensating physicians much more than some of the bosses that we have in these fields. And that's one area where price is an issue. So there are two ways to attack this. Do you find a way to increase the supply of physicians, thus pushing down their wages? Do you regulate and decrease their wages? Or do you find cheaper substitutes to these physicians so that you decrease the cost associated with visiting them? Now, you might ask, well, why is it so expensive? Well, the main reason it's expensive is that we require these physicians to take out a lot of education. And on top of that, this education is quite expensive. The average medical education now costs about $286,000. Students graduate with a mean debt of $186,000. So you have to make entering into the field worthwhile in terms of lifetime income if we're going to get a supply of physicians. That goes back to this problem of, well, how are we going to increase the number of physicians to begin with in order to drive down wages if they're also going to be saddled with such high debt? Now remember, the big component of the big cost was the health insurance amounts. Health insurance premiums have been skyrocketing, and they've been skyrocketing for a very long time. This wouldn't be so bad if worker pay were increasing at the same rate. On this graph, you're going to see a couple of lines. Let's first talk about these lower lines down here. All right, so this light blue line and this gray line here. The light blue line represents worker earnings, and this is in nominal dollars. That is, we haven't deflated them away. Right below it, you see the inflation rate. In terms of real increases in wages, that is, your ability to buy more stuff, what you really want to look at is the difference between this blue line and this inflation line, this gray line here. All right, you can see that from 1999 up until maybe 2006, there was really no change whatsoever in the real wage of individuals. So much of the increases that we saw going on with wages was just to keep up with inflation during that time period. Maybe 3%, right? So we do see a 3% difference here in 2005. So maybe 3%. By 2010, now we see about a 10% increase in real wages. That means there's a 10% increase in your actual purchasing power. So this is good, right? These mean that workers are better off. And that seems to continue straight on through 2015. However, these expenses have not kept up at all with insurance premiums. Right? You can see that insurance premiums, in terms of their amount, have skyrocketed over time. Absolutely skyrocketed over time. So although this difference here between inflation and pay has gone up, a bigger chunk of your real income is going towards your premiums. So in some sense, you are dedicating more of your compensation towards health insurance than you have in the past, even though your ability to buy more stuff has gone up. But here's some good news. There is some good news. The good news is that the cost curve appears to be bending. It appears to be bending. What we mean by that is the growth rate of how much we spend, right? The growth rate, the change of how much we spend on healthcare. These values up here are telling us the percent change in our national health expenditures per capita. Before, we would see these increases that were all above 4%. All right, so that means year over year, the amount that we were spending per individual was going up by about 4% a year. That amount has started to fall. It's still above 0%, meaning that we're still seeing increases in our health expenditures per individual, but at least they're increasing now at a decreasing rate. Our GDP over this time period has also been fluctuating quite a bit. For the most part, it's been pretty steady around 2%, but it has seen recent declines, particularly if you remember the 2008 crash. So why is it important for us to compare the U.S. to other developed countries? Well, health expenditures grew rapidly between 1960 and 1980 for most countries. So it wasn't just a U.S. phenomenon, right? This is not something that is just an American problem. We've actually seen health expenditures grow across the globe. The rates continued to rise into the 1990s and the 2000s in the U.S. by a much faster rate. And the U.S. is the biggest spender in terms of GDP for healthcare. It spends twice as much as the United Kingdom. So as you can see, all nations have experienced an increase over time, right? So here it is in 1970. If we go straight on through from 1980, the gap between the United States and other nations really wasn't there, right? There are other nations that are right along there with us. What happened? We continued to rise from 1980 onwards at a much faster rate than other nations did. We spend a lot relative to other nations, right? You can see right here that these are the amount of public expenditures that the United States have. This is just the dark blue spot. These are the public expenditures that the United States have. Now, at first you might say, well, it's just too expensive. It's just too expensive to do on a per capita basis. It's just too expensive to have the public option all by itself. We spend more publicly than any nation except for Norway on this chart. Than any nation except for Norway on this specific chart. All right, here's the United Kingdom in comparison. Add to that how much we spend privately. And once you do that, you see that we spend about twice as much, if not more, than a comparable OECD nation. Here's again the same graph, a little updated, but the same graph. Comparable nations, $4,460 per person. In the United States, about doubled. $8,745. Switzerland is our closest neighbor. They happen to have a healthcare system that's actually similar to ours. Netherlands, Austria, Germany, Canada, Belgium, France, Sweden, Australia, Japan, the OECD average, which we saw in the previous graph, and then the United Kingdom down at the bottom. Where are these expenses coming from? Well, the biggest reason that we're seeing this big tick up, right? So the reason this big tick up was occurring in the 1980s and onward is that the great baby boom generation is getting older. And as they age, they require more services. Well, look what's happened to our expenditures. When you're young, looking across all these nations, for the most part, we have the same expenditures, right? All these are, for the most part, on top of each other. They're not too different. When we get to our 40s, there starts to be some change, but still not too bad. In the 50s, okay, all the lines are going up, but still not a massive increase. Here we are at 60, particularly at 65, when Medicare kicks in. there is this massive increase in expenditures. And although it's occurring for all nations, meaning that as you age, you are going to need more services, that increase is magnified in the United States and continues to be so straight up until you reach very, very old age. The reason is that we spend about 2/3 of all of our healthcare expenditures in the last third of our life. America's problems rank them as worse on cost-related problems, meaning that the percent of residents who did not fill a prescription, skipped recommended medical tests, treatments, or follow-up, or had a medical problem but did not visit a doctor or clinic because of cost is highest in the United States at 37%, and the lowest in the UK at 4%. Again, I like using Switzerland as our kind of backdrop since their system is closest to ours. There it's only 13%. When we think about inefficiencies, the U.S., in terms of inefficiencies, the percent of patients who report spending a lot of time on paperwork or disputes related to medical bills. In these other nations where medicine is for the most part socialized, there's not a whole lot of paperwork the patient has to worry about. In Switzerland and the United States, where there's a very large, robust private sector, you see there's lots of issues associated with dealing with just paying for your bills, let alone getting treatment. This is just the payment of the bills, the frustration of having to call your insurance company, of having to call your physician, of making sure the bills are correct, of making sure you're actually qualified in order to get that particular treatment or that drug. When we look at overall rankings using the Commonwealth Fund, which, by the way, is one of your readings, and the most recent one should be published, the U.S. is ranked 11th out of these nations, so the worst one. Right behind our neighbors to our north, Canada, at 10. When it comes to quality of care, we do have decent quality measures when it comes to quality of care. In terms of effective care, number 3. Safe care, number 7, about middle of the pack. Coordinated care, number 6. And patient-centered care, number 4. You may be surprised about those values. We are spending a whole lot on healthcare. I hope we do decently. But then we come down to questions of access. Once we get down to access, well, now we're on the bottom third. We're 9th when it comes to access to care. Most of it is cost-related problems. All right, middle of the pack when it comes to timeliness of care. We are dead last in efficiency, dead last in equity, and dead last in healthy lives. And yet we spend the most. And this problem hasn't been improving over time. Right? Hasn't been improving over time. It's been getting worse. In 2004, we were ranked 5th. Not bad. All right? In 2006, we were ranked 6th. And then we stayed at 6, went to 7, and then made the huge jump to 11. One of the reasons that this huge jump has occurred is that life expectancy in the United States is not as high as that of other nations. Some of this is masking lots of other issues. For one, homogeneity of your population helps with life expectancy. But so is income, and we're one of the richest nations on here. Secondly, this is life expectancy at birth. The U.S. has an unusually high rate of homicide relative to these countries, an unusually high rate of suicide relative to these countries, and an unusually high rate of accidental deaths, including drug overdoses, relative to these nations. So this number is really hiding a lot of things. When you condition this on being 65 or older, meaning that you've survived your tumultuous time of life, then we compare just fine relative to other countries. All right, our healthcare system in terms of keeping you alive once you're actually old is still quite good relative to other countries. But if we're only comparing at life at birth, there is some ground to be made. Infant mortality, you may be surprised, as high as the United States. Again, this could do with the immigrant nature of the United States. You can see the UK has some of that going on. New Zealand has some of that going on, and Canada as well. You have this immigrant nature, and in very poor households, you may have higher mortality rates. In one area that we really need to see more improvement in is that when we look at patients relative to their ability to pay, the United States seems to be fairly unequal. Right? There's lots of inequality. In this system here, we said the percent of patients who did not get recommended tests, treatment, or follow-up because of costs in the past year. If you're from a below average income, that number skyrocketed to over 30%. Right? If you're, on the other hand, of a above average income family, then it's just north of 10%. That means a threefold increase depending on your income level. Now, poverty matters, right? You can see that the yellow lines here are higher for all the nations relative to the gray lines. But this is a fairly large increase, and one that is also a high percentage of individuals. The U.S. has higher rates of medication, and lab errors than comparable countries. This is an area where, if you're looking into the business of healthcare, if you could find a way to decrease the amount of errors that a hospital makes, errors that a physician makes, errors that laboratories make, you could save costs. And by saving costs, you can essentially compete away some of these less efficient firms. The United States has a pretty high rate. Canada does as well, although there are companies that are shared between these two. Then the Netherlands and Sweden. It's still not too bad when you consider these other nations. The United Kingdom, on the other hand, has a very low rate, and even Switzerland, which again, for comparison's sake of how our systems are set up, is more than half that of the United States. The U.S. has fewer physician consultations per capita than most comparable countries. Again, think back to our issue of price. We have to pay physicians a whole lot of money. Since we have to pay physicians a whole lot of money, we don't have that many physicians. But when we do see them, we pay them a great deal. Our number of visits is comparable to that of Sweden, which also uses the private sector, so I'm not too worried about that in terms of the system. And surprisingly, it's pretty close to that of the United Kingdom, which seems to be efficient on lots of different measures. The Japanese really seem to like to go to the hospital. But we have this difference here. This is a problem, again, where if you're going to increase the supply of physicians, are you going to do so at a lower quality? Are you going to do so by providing alternative suppliers, meaning using more nurse practitioners, using more physician assistants, things of that nature? This is going to be a hard problem to tackle without, in addition, increasing costs in healthcare. The U.S. consistently has had fewer physician consultation visits than other countries. Here, the dark blue line is the United States, increasing over time. And here are our other countries. Patients in the U.S. have much shorter average hospital stays than patients in comparable countries. The Japanese, again, love their healthcare. The United States We don't like you to stay in the hospital too long. Is that at an increased risk? All right, what does 30-day mortality look like in the United States compared to some of these other nations after you leave the hospital? Is this due to our efficiency in terms of our healthcare quality? Meaning that, okay, cost a whole lot, but if you're going to get in, we're going to get you in, we're going to get you out, we're going to get you back to work. That number has decreased over time for both the other countries as well as the United States, but there is still a 4-day difference between the two nations, or two types of nations. We perform fewer angioplasties, which is, if you think, more preventative, and more coronary bypass surgeries, which is what occurs afterwards, than other nations. Again, here's the United States relative to comparable countries. Here's the United States relative to comparable countries. The United States has seen a continued decrease in angioplasties performed, while other nations have seen an increase over this time period. In terms of coronary bypass surgeries, we have consistently remained above. It's been fairly stable and not a whole lot of changes. Again, these are procedures you're going to perform after a heart attack has occurred, or where we see lots of blockages, so not as preventative. The average price of angioplasty or bypass in the U.S. is higher than that of other comparable countries, in some cases significantly higher. Again, here's Switzerland, where you expect to have the competition at. It is about a third of that of the United States. Again, here's Switzerland compared to that of the United States, about half. The U.S. performs more cesarean sections than most comparable wealthy countries. We do beat out Australia. Australia happens to have more than we do. Switzerland, a little more comparison, although there is about 150 delivery difference there between the two nations. Comparable amount is about 541. Are our mothers that much more of a high risk than those of these other nations? Is there an alternative reason? Is it just convenience, meaning that you want to know a specific date of when it's happening? We have a very high cesarean rate. It's one that we've tried to tackle in economics quite a bit. We may speak about this more later on in this course, or you may have heard a little bit more about it in our health economics 1 or 2. The average price of a cesarean section in the U.S. is more than the price of a normal delivery. All right, and so here's the price of a normal delivery, $10,000. That of cesarean is $15,000. The U.S. leads comparable OECD countries in MRI availability and use. And so we like our imaging. We have lots of places for you to get your imaging. All right, and we take lots of images. Some of this could be defensive medicine. Some of this could be, look, we have this tool that can better inform us about diagnostics. We're going to use it. But we have quite a bit of that relative to other nations. This wouldn't be so bad if the cost of that image weren't so high relative to that of other nations. In Switzerland, again, similar system, only $138 in order to get that image. We're talking about almost a 10-fold increase in the United States. The average price of Celebrex in the U.S. is about 63% higher than that of Switzerland. The average price of Cymbalta in the U.S. is 76% more than the average price of that in Canada. Right? The average price of Nexium in the U.S. is almost 3 times more than the average price in Switzerland. Hopefully what you're hearing from all this is that price is the major driver of cost in the United States when it comes to healthcare. It's the major difference between our cost here in the U.S. versus abroad. It's price. On the pharmaceutical side, a lot of that is driven through patents that we have in the US. So you're going to continue to see these differences. We can argue about how to deal with these patents, and we will during our pharmaceutical section. But on the case of hospital stays, that is an area that we need to attack more rigorously. What has all this brought us? Well, when you think about the different ways that people die, the beauty of modern medicine is that communicable diseases are at their lowest that they've ever been. That's the beautiful part. Instead, we are dying of internal diseases. Right? We are dying of cancer, which has grown in the US. We are dying of cardiovascular or circulatory diseases, which again is higher in the US. We are dying of muscular disorders, of diabetes, of mental and behavioral disorders. All these are occurring in the US. In this chart, what you see here is these are the number of years lived with a disability by age for 20 broadband groups. Mental health, which is this darkish grayish area here, sits right in here. It is about the same as other places. Larger, surprisingly to me, it's about the same for all ages, much larger occurring in your 40s and 50s. These are individuals living with these disabilities. When we look at cancer, though, cancer rates have been creeping up over time, and they seem to be peaking in this 60 to 65 area, which is right about the time where they jump on Medicare. One of the benefits of having a modern medical system is that people die of more and more advanced things. Right? At some point, neurological diseases are going to be the big issue in the United States because we have done such a good job of taking care of diabetes and such a good job of taking care of cardiovascular systems and such a good job of taking care of cancer that it will be neurological, your brain just dying on you, that's leading to death. For most of the leading causes of death, mortality rates are higher in the U.S. than in comparable countries. Here, the U.S. again is the blue. So we have more folks dying of circulatory systems, fewer dying of cancer, more dying respiratory, smoking here. External causes of mortality, again, drug use, suicides, murder. Disease of the nervous system. I expect that number to continue to go up. And as that one goes up, I expect this one to go down, and hopefully this one to go down. Mental and behavioral disorders, and then the endocrine system. The U.S. has the highest rate of death amenable to healthcare among comparable OECD countries. And France has seen a decrease. Austria, about other nations have all seen a decrease in amenable healthcare. The U.S. as well has seen a decrease, so it's not completely fair, but we do have still the highest rate among them all. So where does this leave us? Well, when you think about comparing healthcare systems across different countries, there are about 4 models of healthcare that you need to internalize. The first model is called the Beveridge model. And in this model, healthcare is provided and financed by central government via taxes. That means that the central government is both the insurer as well as the supplier of healthcare. So if you are a physician, you are a government employee. Hospitals are publicly owned. Your health insurance is coming from the government. This is a very, very centralized system. The United Kingdom has a system, Spain, Scandinavia, New Zealand, Hong Kong, and Cuba. The Bismarck system. All right, the Bismarck system is you have an employer-based insurance. Now you have an employer-based insurance system. Providers are private. We see countries like Germany, France, Belgium, and the Netherlands, Japan, Switzerland, and Latin America that offer these types. The difference here being that only Switzerland doesn't also provide this kind of public option. Then you have the national health insurance. National health insurance, it has a single payer system, so there's only one health insurer. You don't have private insurances competing in there as well. Again, the providers are private providers. So you are not a public servant, you are a private provider. But you must negotiate with the National Health Insurance Agency in order to get your prices. Canada, Taiwan, and South Korea all share this method. There is also areas where there is no centralized model of healthcare, and out-of-pocket is really the only way that you can get services. Only about 40 developed nations have a model of healthcare that use out-of-pocket systems. Only about 40 developed nations have a model of healthcare, meaning a Bismarck, Beveridge model, or national health insurance model. And everyone else treats healthcare like any other market and pays out of pocket. The interesting part about the United States is that it has a piece in essentially all of these, right? It has one where healthcare is provided and financed by the central government via taxes. That's the VA system, the Veteran Affairs system. It has national health insurance when you think about Medicare and Medicaid. It has employer-based health insurance when you think about what you get from your employer. And then we have other people who just have straight out-of-pocket expenditures where they have no insurance at all and they're willing to pay for the visits. After this short video, I hope that you also look at Sick Around the World so you can get a better understanding, as well as the healthcare triage, quick snippets about individual countries and how they deal with health, so that you can get a better understanding of how Germany and France are different and how UK and Spain are different. That's it. Thank you.